So good afternoon, everyone, and welcome to the ID-EPI seminar series presented to you by the Center for Communicable Disease Dynamics and the Harvard T.H. Chan School of Public Health. This is the 7th seminar of the series. I'm Flavia Camponovo, and I will be moderating this session. We are excited to welcome with us today Dr. Koen Pauwels. He is a senior health economist at the Oxford University's Health Economic Research Center, and his work has informed national COVID-19 mitigation strategies, as well as national targets for antibiotic prescribing in the United Kingdom. Before we get started, let's cover a few logistics. So this seminar is being recorded, so please turn off your camera if you do not wish to be recorded. The recording will be available on our website at a later point in time. Dr. Pauwels will have approximately 40 minutes for his presentation, and then we'll stop for questions. Throughout the talk, you can send questions via the chat function to Benedict, and you're welcome to ask your question yourself. If you wish to do so, please specify this in your message to Benedict and we will call your name during Q&A. So we are thrilled to have Dr. Pauwels with us today as he describes improving the use of existing antimicrobial resistance data and generating better data on optimal antibiotic duration by improving trial designs in veterinary and human medicine. Prior to joining the University of Oxford in 2019, Dr. Pauwels worked at Public Health England on various projects related to antibiotic usage and antimicrobial resistance. His current work covers an extensive range of research activities, such as SARS-CoV-2 and antimicrobial resistance modeling, spatiotemporal modeling to predict local antimicrobial resistance and SARS-CoV-2 infection prevalences, design of randomized trials to determine optimal duration of antibiotic therapy, economic evaluation of antibiotic resistance-related interventions, and development of statistical approaches to better quantify the impact and resistant infections on health and economic outcomes. So thank you for joining us, Dr. Pauwels, and without further ado, let's get started.
Thank you, Flavia, for the very elaborate introduction. So the title is already mentioned. So before I was completely derailed by COVID, I indeed worked a lot, most of my time spending on AMR related questions. And some questions that are mainly focused on is what is the influence of changing antibiotic exposure on antibiotic resistance? And that's the part where I will mainly focus on during this talk. And a second question that's also a bit challenging to address that I focused on in my prior work a lot is whether patients increase their healthcare usage and stay longer in the hospital, intensive care, or are more likely to die with a resistant infection or due to a resistant infection. Initially, when I created this talk, I was planning to also talk about the latter, but I had too much to say about the first part, so I'll mainly focus on that. So first, a bit of a background about the challenges with estimating the impact of antibiotic use on resistance. So historically, many studies actually link antibiotic use and resistance, focuses simple associations or correlations between use of antibiotic A and resistance against the same antibiotic A. However, in reality, relationships are probably much more complex. So one of the issues I've been working and thinking about over the few years is co-selection and cross-resistance via either related antibiotics from the same class, but also unrelated antibiotics. For example, if resistant genes of unrelated antibiotics are based on the same plasmid, then prescribing antibiotic B will also select for resistance against antibiotic A. Of course, treatment with one antibiotic may simply kill competing bacteria, providing basically a space and food for other bacteria. There's a nice example for a VRE, so vancomycin-resistant enterococci, in the trial of anaerobic antibiotics. Intriguingly, resistance against one antibiotic may also confer sensitivity against another antibiotic. This is something that has been mainly investigated in terms of point mutations. And something that's increasingly recognized is that treatment of respiratory tract infections and other infections, even if it's viral, may increase resistance potential of the microbiome via so-called bystander exposure, because antibiotics have a systemic effect. And of course, relationships might not be linear, and while increased usage of antibiotic use might result in increased resistance, the reverse is not necessarily always true. So thinking about whether we really should make more complex models and think about the use of other specific antibiotics is something I started working on when working at Public Health England. And what we did is, well, basically going into quite agnostic and think about, okay, can we in an explorative way evaluate which antibiotics are associated with trimethoprim resistance among Enterobacteriaceae urinary samples. So we had quite a few samples, over 2.5 million from different areas across the UK, or England to be precise. And we fitted a generalized boosted regression model to explore whether certain antibiotics are associated with trimethoprim. And unsurprisingly, we saw quite a nice, in the left bottom corner, quite a nice relationship between trimethoprim use and trimethoprim resistance. And in the top row, so the right the right block with a blue square around it is for amoxicillin. So amoxicillin was associated with an increase of trimethoprim resistance, and intriguingly, in the left-hand top corner, nitrofurantoin was associated with a decreased trimethoprim resistance. And this is all from a model that includes all antibiotic groups at once. And in follow-up work, we looked at other resistances among E. coli again. And we found that amoxicillin use was not only associated with trimethoprim, as we found here, but also with, unsurprisingly, amoxicillin and also ciprofloxacin. And this is something that actually quite nicely lines up what we know from biology. And for example, a clonal group ST131, which is quite a common E. coli group, is often non-susceptible to both quinolones such as ciprofloxacin, trimethoprim, and beta-lactam antibiotics. So it kind of makes sense that there is some co-selection happening there. So in terms of the negative relationship between nitrofurantoin and use and trimethoprim resistance, it is something that probably inspired other people also to look at that in the Netherlands. And they basically found a very similar finding, that if you have higher use of nitrofurantoin, you tend to have lower resistance of trimethoprim after accounting for levels of trimethoprim in your area or in persons. And probably one of the more convincing examples of co-selection is probably the quite famous Mordor trial, where mass distribution of azithromycin, which is a macrolide. So entire villages were either randomized to this mass distribution or not, to preschool children. And they found that quite a while after the intervention, they found still strong selection for determinants of non-macrolide resistance, including resistance to beta-lactams. And more generally, it's quite well known that resistance genes tend to cluster, so making co-selection actually quite likely in many situations, especially for bacteria that are commonly carried in the gut, or basically part of your microbiome a lot of the time. So this also nicely leads to some work that maybe some of you on the call actually have done, that was published in PNAS, is basically focusing on trying to quantify to what extent bacteria are exposed by antibiotics directly targeting them, and to what extent it is by being bystander exposure, either directly via being a potentially pathogenic bacteria being present during antibiotic treatment, or you could also think that resistant genes get passed on to bacteria that aren't present during antibiotic treatments, but they might get it from commensals. Of course, there's increasing evidence from trials, but something I have been wondering over the years, at one point when this became a bit more of a hot topic, is that if bystander exposure would play an important role, I would also expect resistant prevalence among different pathogens to correlate, at least at a geographical or country level. And this is something I've meant to write up for quite a long time, but of course being derailed into all kinds of other work, I haven't done this yet. But this is an example of what I did. It's simply looking at, so on the right-hand side, we have data from the ECDC, so the ERS network, which gave blood samples for different pathogens. And as you can see, there's quite a strong correlation between fluoroquinolone resistance among different types of pathogens. So the correlation factor, I don't know whether you can see it, but it's between 0.65 is the lowest, and range up to 0.83. And if we do something similar with, I think these are any specimens, if I remember it correctly, from states in the USA, from the Resistance Open database, you tend to see also positive correlations, although potentially slightly less strong in some cases. So the next challenge or tricky thing is, are all resistance reversible? So there are some really nice papers and reviews written about this by, for example, Dan Anderson. And essentially it boils down that selection of resistance essentially depends on the benefits and the cost of resistance. And there are several successful examples where policies and interventions reducing specific or overall antibiotic use were associated with substantial reductions in resistance. There are plenty of examples, especially in hospitals, where there were quite quick and drastic changes in resistance. But there are also some very noticeable exceptions that made some people very skeptical about whether we can actually reduce resistance by reducing prescribing. For example, probably one of the more famous examples is an intervention study in Sweden where there was a 85% reduction in an area, in an intervention area, and it basically didn't hardly see any effect on trimethoprim resistance subsequently. And it's important to note that this reduction was accompanied by an increase in another antibiotic. So it might have been that the absence of an effect might have been due to co-selection. So in terms of another example we've written about is cotrimoxazole resistance, and this is related sulfonamide resistance, and that actually remained high decades after substantial reduction of cotrimoxazole, suggesting that it might never go away. And one of the explanations is, again, maybe co-selection, but also so sulfonamide resistance is a bit of a weird example where resistance actually conferred a fitness advantage instead of a fitness cost. So you would also expect it not to go away too quickly. So then I got completely distracted by COVID, like many of you on the call, and probably many of you on the call also might by now regret it a bit. But what I've been doing for that is I've co-designed the UK's national COVID-19 infection survey, which is one of the largest SARS-CoV-2 surveys in the world. And to basically get representative estimates of prevalence and incidence over time, I've further developed spatial temporal multi-level regression and post-stratification, or MRP. And what I'm currently doing in the few moments I still have time for AMR work is apply this methodology to get more representative estimates of resistance prevalence across the UK based on non-random surveillance data. So I'm quite pleased that since recently we get hospital level antibiotic prescribing data from IQVIA for this, which is quite useful because before all my analysis were based on only publicly available data, primary care prescribing data. And as you can imagine, there's probably hospital prescribing can be an important driver of resistance. And then I'll focus on urinary samples submitted by general practitioners to Public Health England second generation cephalosporin surveillance system to assess the associations between use and resistance, and then taking into account co-selection and sampling bias. So in terms of spatial MRP, I can basically use this to provide sub-regional estimates of prevalence of antibiotic resistances of interest, accounting for non-representativeness, so oversampling of a particular type of individuals with certain characteristics or particular areas. But of course, this comes with some challenges. So you might end up with small numbers if you zoom in too much. You need to take into account potential spatial autocorrelation that remains after including covariates of interest. And there is, given the constraints I have to work in regarding infrastructure, the running time is an issue where proper MCMC is probably not feasible. So I'm implementing this using integrated nested Laplace approximations. So one solution to overcoming running time is actually just focusing on snapshots in particular particular times. But unfortunately, that becomes a bit complicated if we want to look at the influence of lagged antibiotic use on resistance. But Gao et al. Previously developed or proposed to use spatial priors and structural priors for MRP. And basically I'm building further up on this. So what they've done is use a BSEP York Molly, a BIM2 specification as a prior for the structure of the area effect, which is quite a common prior for spatial analysis, which includes a mixing parameter rho, which is kept at, in this case, the default BIM2 hyperprior specification in lab. And we're using penalized complexity priors to avoid overfitting and making the model too complex. And in a simulation from Gao et al., they basically found that when they actually simulated the spatial structure in the underlying data, that the absolute bias for almost all areas significantly reduced when using a spatial BIM2 prior instead of a typical IID specification, which is essentially just a standard random effect. And the attenuation in absolute bias was most apparent with small sample sizes. And this is probably also true with a rare outcome. And when zooming into one single post-stratification cell, and a post-stratification cell means then someone with a group of individuals with the same age, same sex, same ethnicity, and other covariates you have in your model, then the spatial prior always outperformed the IID prior in terms of absolute bias reduction. And posterior widths were also comparable between the two, so you don't lose power by using a spatial prior. And importantly, even when simulating outcome data as a multivariate independent normal, which is kind of basically means that IID would be the most appropriate choice, the BIM2 spatial prior in combination with a penalized complexity prior produced nearly the same posterior estimates as the IAD prior, indicating that it doesn't force a spatial structure when it's not present. So now I wanted to show the results of this analysis, but unfortunately that is not possible due to derailing into COVID. But this gives a nice example of the kind of data that's going in terms of total antibiotic use. You do see, at least in the UK, you see quite a big seasonality effect. If you go to countries which have much less antibiotic prescribing, such as the Netherlands, where I'm originally from, as you probably can hear, the seasonality is much lower. And the seasonality is mainly in respiratory tract antibiotics, such as amoxicillin, which is one of the most commonly used drugs, antibiotics in the UK. And as you can zoom in into the percentage that is of your E. coli samples that is resistant to amoxicillin, you see a very nice similar seasonality pattern, with a slight lag, but it really nicely follows the amoxicillin use, suggesting that at least for amoxicillin, reversibility among E. coli is also a thing, because it moves up shortly after use goes up, but also it goes down quite quickly after use goes down. So what I'm currently doing is using a beta binomial model to account for overdispersion and accounting for age, sex, geography, area-specific covariates, such as primary care and hospital antibiotic use, and using a BIM2 spatial prior, and extending the model from Gao et al. By adding random walks for time and potentially nonlinear lagged effects of relevant antibiotics. And what I'm particularly keen to see and hopefully be able to show in the next 2 months is hopefully we can get an update after substantial reductions that were observed in antibiotic prescribing in the UK. For example, if we compare April, July 2020 to the same period in 2019, we saw a 14% reduction in primary care antibiotic use, and this effect was even larger for penicillin, where there was reduced by a quarter, which isn't overly surprising, but the reductions are huge. So let's go talk about the duration of antibiotic treatment. So my interest in antibiotic duration started a few years ago when I was I was about to start working at Oxford, but before, when I was working at Public Health England, we were commissioned to quantify how much of antibiotic prescribing is inappropriate in primary care in the UK. And while after doing that, I thought, well, why don't we also look at duration? Because you can not only quantify how much prescriptions are probably completely unnecessary, but a lot of prescriptions might be even longer than guideline recommendations. So this is some work we published in BMJ a few years ago. And as you can see, so this is a small selection of all conditions that we looked at, but for most common infections treated in primary care, a substantial proportion of antibiotic prescriptions have duration exceeding the recommended guidelines. So suggesting that there is some potential to reduce prescribing safely, provided that the guidelines are correct. And of course, that you would expect that some people would receive longer courses, but not the majority, as is the case for some conditions. However, when zooming into the guidelines and looking at what the underlying evidence is about the optimal duration, we also found that the evidence underpinning these recommended guideline durations was sometimes actually quite weak. And if you think about infections that that are typically cured with a fixed treatment course. That is something that happens typically in primary care, especially because you only see a patient once when they visit first or have their consultation, and then you decide, okay, we're giving you 7 days of treatment, and you don't see them afterwards if everything goes well. But there is a push towards reducing antibiotic prescriptions and also infection medication in general. Of course, hepatitis C is a prime example where reductions are necessary to reduce costs and make it affordable in low and middle income countries. But in terms of bacterial infections, we know that durations are typically just based on a precedent. So in Europe, for example, and probably the US as well, it's often 14, 7 days, 3 or 5 days. While in South Korea, where odd numbers are unlucky, they don't use the odd numbers, but they use instead 4 and 8 days. And a key motivation for a short duration is that we're concerned about resistance, and actually a lot of the resistance we're really worried about arises via bystander exposure, via exposure to gut commensals as a byproduct of urine infection elsewhere. So, and also if you think about potentially viral infections, we really want to reduce that, to reduce resistance among that goes via bystander exposure. So how do we typically work out whether a short duration can be used? Well, traditionally, we take the standard duration, for which typically is no or very limited evidence. And then we choose an arbitrary shorter duration for which we have an idea like, well, maybe this duration of 4 days might be quite similar in terms of cure, so let's do that. And then potentially repeat this over and over again if the first one is first non-inferiority trial is successful. And then of course you have the risk of a so-called bio creep, where some people also recently wrote something about. And this is a longer running concern of the FDA about non-inferiority trials, because if each subsequent trial you use the newer shorter duration that is not inferior to the previous control, but it's actually slightly worse, but still within the margin, you see that you gradually go down. And actually the duration you end up with might be quite inferior to the original longer duration. But how do people do typically such a non-inferiority trial in practice? Well, they compare 2 arms and typically really need a very large sample size. So in terms of the issue of a sample size, so these are some quick sample size calculations we've done. Suppose we have a failure rate of 10%, and we fix a 2-sided alpha at 0.05. Of course, there's a bit of discussion whether it should be 2-sided or 1-sided in the literature, but let's go for 2-sided here. You quickly see from this table that if you go down and you want to have a smaller margin, the required sample size drastically increases to quite infeasible numbers quite quickly. And of course, this is an example for 10% failure rate, and numbers might go even more drastically up with different failure rates in the control group. So then we have the problem of generalizability. So there are some larger trials that, for example, showed for pyelonephritis that 7 days of ciprofloxacin is non-inferior to 14 days of ciprofloxacin, which is good news. And same 5 days of levofloxacin, which is also a quinolone, is non-inferior to 10 days of ciprofloxacin, another quinolone. But in the UK, at least, hardly anyone uses quinolones anymore, and it's really recommended to try to avoid this drug because of side effects and I believe, a black box warning even, and also thinking about C. difficile, diarrhea, etc. And what in practice, at least in the UK, the doctors typically use beta-lactams for which there is no evidence that a shorter duration is as good. So people typically get 10 to 14 days of beta-lactam for pyelonephritis, but it might be possible that much shorter durations are actually as good. So going to the next problem, if you choose unwisely your shorter duration, and it's actually worse than your longer duration, as in this example, if you choose a duration that's just a little bit shorter than the minimum that retains an acceptable efficacy, so the difference between 3 and 4 in this picture, when for the solid line, then you've completely wasted everyone's time, basically, when you conclude that the shorter is not non-inferior to the standard duration. And basically, we want more than just 2 estimates, as this plot already tells you. You want to model the entire duration response curve. And how to do this? Well, basically, you need a multi-arm trial where you randomize patients to different durations. And this has another advantage if you think about infections. Probably it's true for a lot of infections that some people only need a few days of or a short duration of antibiotics as a kind of kickstart for the immune system to take over, while more immunocompromised individuals probably need a longer duration. So you could potentially also investigate different shapes for different subgroups using such a multi-armed study. So this is more about when we proposed this type of design to clinicians, and when veterinarians reached out for help. Something that we always discussed, and what was brought up was, should we consider dropping arms? And I think that's partly because of efficiency and costs. And one of the initial reasons for increasing interest in adaptive designs, there are of course many other reasons, but under certain circumstances, they are statistically more efficient. However, thinking about infectious disease, you probably need to have a time-stratified analysis if the randomization probabilities are changing over time, because infectious disease is often changing. And the problem is preferentially allocating to best performing arms not only removes that arm, but also affects the neighboring arms, so it reduces precision around the duration, the other durations of the curve. And thinking about subgroups, dropping arms reduces the ability to detect subgroups that can safely receive shorter durations. And you could argue, well, then just use subgroup-specific randomization probabilities, but essentially you will probably have no power to do this based on subgroup-specific response at interim analysis, because you won't power your study on that. So is it really feasible to randomize to multiple arms? Well, so this is some work that Matteo Cartagno from UCL did, some simulation studies, and he found that if you fit a polynomial logistic model with cure as outcome and duration as the only covariates, and then using 2 polynomial terms, he found that you can adequately capture the true likely true duration response curves if you have about 500 patients divided into 5 to 7 arms with equal distance between the different arms. Then that is sufficient to estimate the entire curve with a 5% error margin in 95% of its simulations. So if we create such a duration response curve, the next question is, how should we use it? Because we can estimate the curve, we can look at it, but how to judge what is then the optimal duration? Well, there are basically 2 options. So first of all, you can use bootstrapping to estimate a confidence interval around the optimal duration. So that's in our case, it's probably the minimum duration corresponding to a cure rate of at least the cure rate of the longest duration minus the non-inferiority margin. So the other approach, which I probably favor, is using a bootstrap to create confidence intervals around the difference in efficacy, so cure rate between each duration and the longest duration. So if you do that and plot that, you can actually compare against any duration specific or a horizontal line, non-inferiority margin that indeed may differ between different uses of the trial. So everyone can kind of plot their own non-inferiority margin on the duration response curve with basically on the differences. And in simulations, both approaches have good operation characteristics. So in terms of type 1 and 2 error in a wide range of simulated scenarios. So let's go to an application. Probably good to provide some perspective about antibiotic use in the UK, which is probably quite different to some other countries. In the US, I believe there is much more antibiotic use in animals, but also, while in the UK, most antibiotic use is actually used for humans, and this actually improved over time in the sense that there was very large reductions in prescribing for farm animals, but actually over time, between 2013 and 2017, actual antibiotic use for companion animals has increased over time. And this application will indeed talk about dogs and not about sheep. So to provide a bit of background for those that are not, well, are only familiar with their own dog, is that urinary tract infections are one of the most common infections in dogs. So it's affecting roughly 14% of dogs during their lifetime. And of course, antibiotic resistance is not only a concern among humans, but also among animals, especially those that are living a bit longer, such as pets. And importantly, companion animals may act as a reservoir of antibiotic resistant infections for humans, especially given the frequent close contact interactions. So I think this picture is quite telling about the current state of the guidelines in the UK, at least. So the recommended duration for uncomplicated cystitis in females is 3 days of nitrofurantoin. And of course, nitrofurantoin is a drug that has relatively little impact on resistance compared to other some other antibiotics such as coamoxiclav, which is recommended for 7 to 10 days for this little friend here in the left-hand corner. So in terms of current evidence on treatment duration in dogs, this is very limited. So there's a trial from 2014 among 38 dogs that compared 3 days of cotrimoxazole to 10 days of cephalexin, so making a comparison between two different antibiotics. And they said it was 3 days was non-inferior based on the absence of statistical significance. And hopefully you all realize that it's not a really good design, especially not with 38 dogs. So another study that looked at, again, compared two different antibiotics, and again, underpowered to really assess what's going on in 2012. So we basically don't really know what's optimal treatment. So when we wrote after we wrote a paper on duration response, how to set up these type of trials in BMC medicine, some veterinarians approached me and asked, okay, can you help us setting up a duration trial, because we really don't know what we should recommend in the guidelines, and we're currently drafting guidelines, so it would be helpful to get some more robust evidence about what we should be doing. So a couple of practical questions that we had is, should we randomize practices as a whole, individual dogs, or quasi-randomization using day of the week? Something that's important to realize is that veterinary practices are probably not exposed to previous trials, so they're not used to being part of research and trials. And management between practices is actually quite different. So randomizing different practices to one duration, a specific duration, is probably not really the best thing to do. And it might also not be acceptable by individual practices. And of course, we had to work with a limited budget because there's just less funding available for research in animals than in humans typically. So what in the end, what we decided is to be pragmatic and use a number of durations for coamoxiclav, which is currently still the recommended duration. And although I would have loved to use a different antibiotic, it was probably not going to be acceptable by vets to both potentially shorten the duration and use a less broad spectrum antibiotic. So we assigned them to 5 duration, and the study is called Stop on Sunday. So if you start on Monday, you have 7 days of treatment. If you do Tuesday, 6 days, and on Friday, 3 days. Of course, you can worry a bit about Monday to Friday effect. On Monday, dogs might be slightly more likely to get sicker, and on Friday potentially less sick, especially if you take into account the cost of a veterinary visit, especially during the weekend. So what we'll do is adjust for time since onset of symptoms in a regression model. So and then again, we will perform some sensitivity analysis to some quantitative bias sensitivity analysis, but my suspicion is that this will have an unlikely a major impact. So in terms of outcome, we're looking at the proportion of dogs that are reported by owners to have a resolution of clinical signs the day after completion of the antibiotic course. The proportion of dogs that receive an extension of antibiotic use of therapy, and those that develop recurrence of lower urinary tract signs within 4 weeks of presentation, and microbiological cure. So in some considerations is that we have to do is that not all dogs presenting with lower urinary tract signs will actually have bacterial UTI. This is estimated to be at 75%. And given that we have a non-inferiority trial, we really want to be powered for dogs with real UTI. And clinical cure rates, which is a primary outcome, is expected to be 75%. So if we actually did simulations, we found that we roughly need about 700 dogs to get desirable properties, but we inflated by the 75%. So we're aiming to recruit 934 female dogs approximately. And we'll use, similar to what I've discussed before, estimated duration response curves using fractional polynomial logistic regression with time as onset, since onset of symptoms as an additional covariate, and use Bootstrap to get for each duration the difference between the duration and the longest duration, which is 7 days in this case. And then we will pick the shortest duration for which the upper confidence limit is below the acceptability frontier. So the current status of the trial is that dogs are currently being recruited. Of course, recruitment got delayed thanks to COVID, but we managed to get our first dog in the trial in February, so that was good news. And if this actually is going to be successful and feasible, I think this opens the door for similar studies in companion animals and also farm animals potentially. And I think this is especially relevant given that evidence on optimal duration is generally completely absent in animals or very weak. So it's probably even a worse situation than in humans. So in terms of what we're currently doing is I'm currently designing a randomized antibiotic duration trial for humans as well, for upper and lower urinary tract infection. And hopefully we're aiming to measure impact on gut microbiome to further our understanding of the impact of antibiotic duration on, well, basically the bystander effect. And hopefully also use the trial data to build accompanying models of within host dynamics for different antibiotic durations. So we get a really better understanding of what the relationship is between antibiotic duration and its impact on resistance selection. So there are lots of people I need to acknowledge. So all my co-authors, Matteo, who helped with designing and coding the trial methodology, and of course the veterinarians I work with from the SOS UTI study group and funders. And if you have any questions or comments, happy to say it now, but you can also email me on this email address after the seminar. Thank you.
Thank you very much, Dr. Pauls, for such an insightful presentation. I think we have 10 minutes for some questions that we'll take from the audience, and we'll try our best to accommodate any questions we have. However, if the question doesn't get covered, please feel free to reach out, well, to us or to Koen. Remember to submit your questions to Benedict. And I think we can start with the first one from Edward Goldstein. I believe you can ask your question yourself if you have your camera on.
Yeah, thanks for this talk. I think there's indeed a lot of interesting topics. So I have actually two questions. So first, about the relation between nitrofurantoin use and decrease in trimethoprim resistance. So nitrofurantoin and trimethoprim are both used heavily for UTI. So when you use more of one of nitrofurantoin, you use less trimethoprim, and that's part of the reason why resistance declines, and not necessarily through use per se. I think the example from Sweden also confirms that there was a decline in trimethoprim use. There was an increase in nitrofurantoin use, but not much impact on resistance. So once again, I think it shows the limitation of some of the regression models in capturing the effect of one drug on the other, because there are all sorts of confounders. And another question, which is perhaps more substantive, is that in England, resistance levels for some of the key pathogens that cause most of bloodstream infections, particularly E. coli and Klebsiella, they're growing, they're not decreasing, they're increasing, while outpatient use is decreasing. And part of the reason is that there is also inpatient use. So I've just looked up the latest report, which says that over a 5-year period, 2014 to 2019, outpatient use of antibiotics declined by 12.2%, but inpatient use increased by 13.4% in England. So I think that using outpatient data only to understand the dynamics of resistance is not really feasible, frankly. It's just because the inpatient data may be even more important for some pathogens.
Yeah, so if I can start with the latter, that's exactly the reason why basically halfway the talk, I talked about getting access to hospital data that we now have. Initially, it was quite hard to get hold of that data, but we do have data now, and it's actually something we're incorporating into our models, because especially for resistances like quinolones, which are probably primarily used in hospital antibiotic use, in hospital setting, that's very relevant. For other drugs, where we so for some resistances, we see already, if we don't take into account hospital use, very plausible relationships. But of course, I do acknowledge that these can still be confounded. But I think it will be especially important for the resistances where there's clearly a lot of antibiotic use in the hospital, either via direct or via co-selection. So that's definitely something we're taking into account. In terms of the example of having lower trimethoprim use in Sweden, this actually had nothing to do with nitrofurantoin being increased. So in Sweden, they increased bifmacillin in that setting, and bifmacillin had already before the trial had a lot of co-selection potential, because basically bacteria that were resistant against trimethoprim tended to be also have resistant genes against bifmacillin. So that had less to do with nitrofurantoin. And if you actually go to the actual UK data and you randomly sample E. coli, for example, the resistant rates against nitrofurantoin are extremely low. So basically, I think it's a valid point in the Sweden setting. I'm less convinced that nitrofurantoin is really causing co-selection. But as you say, of course, if nitrofurantoin is lower, trimethoprim, there's a relationship between use of trimethoprim and use of nitrofurantoin, and it's an inverse relationship. I mean, it's not perfect, but actually, even if we compared in areas with similar use of basically by including it both into the regression model, you condition on having similar levels of other covariates. And even if we try to restrict to see whether we can to certain areas where the difference, where you have basically similar levels of trimethoprim and different levels of nitrofurantoin, we still saw a similar effect. But I do understand that it is not perfect. But at least we didn't do a model where we had separate. We always included both nitrofurantoin and trimethoprim and did some sensitivity analysis there.
Thank you. I'll just read out the next question from Lenora. To what extent has the inferred relationship between resistance and duration of treatment been shown to be true? Suspecting that there is a large variability by antibiotic mechanisms or drug combinations.
Yeah, I completely agree. That's one of the reasons why we also want to have basically use metagenomics in the trials that we're going to that we're currently designing, because also when discussing it with clinicians, we're basically not entirely convinced that the shorter duration is necessarily the best for the targeted pathogen. What I do think is probably in terms of bystander exposure, that relationship might well be true, that the shorter you give antibiotics, the better, because you just have less bystander exposure. And that's the main reason why people think, okay, shorter is probably better. But in terms of targeted pathogens, I'm not convinced, and I don't think there are a lot of people that are convinced that it's necessarily better. There might well be reasons that it's actually worse, but that's one of the reasons why we want to actually test it in a trial and see what's better. Because one of the arms is actually with trials where we have longer durations than is currently recommended, partly to figure that out.
That's really interesting. I think it's somehow counterintuitive, so to understand these length of treatment and the relationship to resistance. And we have here a question from Jonathan. What do you anticipate is the impact of COVID-19 on antibiotic use and thus on resistance? Back on COVID a little bit.
Well, in the short term, it has at least in the UK and also in the Netherlands, where I know it's for. I think in a lot of places, it's substantially reduced antibiotic prescribing in primary care. In hospitals, I'm also doing a study with people in intensive care in London, and their antibiotic use went drastically up. Partly because there were so many patients at the same time in such a basically sharing bed spaces that where you normally have one patient, you suddenly had 3 or 4 patients. So there was a lot of transmission going on, and what they were saying, basically they saw probably in 6 months the amount of hospital-acquired bacteremias, what they would normally see in like 10 years. And there were lots of transmission going on. So probably hard to say what's better. I suspect it's probably dependent on what antibiotic you're interested in, what the influence will be on resistance. So I'm keen to find out what happens. And of course, you also have probably reduced transmission of for certain pathogens, resistance transmission of the resistant genes might be more relevant. So for those where transmission may matter, you also have other effects, not only through reduced use of antibiotics, but also reduced contacts and hence transmission. So I think big question mark, I don't know. We'll see. But what it will be interesting is what long-term will happen in terms of antibiotic use in primary care, for example. Will that remain low, or will that just gradually go up and maybe even increase? Because what we do see in patients that do consult, that the consultation rate went down drastically, but the ones that do consult, then you actually see that per consultation antibiotic use went up, which is also not overly surprising. But yeah, we'll see what happens.
I think in the sake of time, I'll just ask one last question. We have here one from Scott Aldenson, who is curious about where lags between antibiotic use and resistance come from. In an individual, antibiotic use should lead to immediate resistance. At a population level, maybe selection of resistance in one person needs some time to diffuse to others, as resistant bacteria are transmitted and overcome colonization resistance. Can any of the data from the UK distinguish these routes and the quantification of a lag?
Yeah, it's a difficult one. So basically, what I'm doing at the population level is essentially looking at different lags and seeing what's essentially the best model fit. But I don't have access to at the moment to individual level data at the same level. But I think that trials at least will potentially say something about the individual level effect for the particular things we're looking at. So the particular antibiotics that we're focusing on. So it will give some answers, but I think it will be highly dependent on both bacteria resistance. This is also one of the things that makes it so complex. Everything depends on what specific thing you're looking at, and it's probably not very generalizable.
Yeah, I think, yes, we're out of time. So thank you again. And on behalf of the Center for Communicable Disease Dynamics and the Harvard T.H. Chan School of Public Health, I'd like to thank Dr. Pauls for joining us today, and also thanking you all for tuning into this IDEPI seminar series. Please check out the CCDD website to stay up to date on upcoming seminars and other events. So thank you again.
Thanks.